Disclosures and our learning objectives for today. So we'll define what CKM syndrome framework is and its relevance to clinical care, identify interventions that simultaneously address cardiovascular, kidney, and metabolic risk, and then integrate CKM prevention and management strategies into primary care practice, and finally help identify some NKFM self-management programs and encourage integration of NKFM evidence-based programs to improve outcomes and mitigate disease burden. So we're going to start with a little bit of a case, and this is more kind of just a case for thought. So you have a 52-year-old woman who presents as a new patient. She has no complaints today. But we look at her exam and we look at her labs, and we see that she has a BMI of 31. She has an A1C of 6.1%. She has a blood pressure of 145/98, an EGFR of greater than 90, but albuminuria of 100, an ALT of 48, which is slightly elevated, and an AST of 42. So, what are your thoughts about this patient? And I would love some interaction here. If anyone wants to pop anything in chat, or if you want to, raise your hand and talk, what are your thoughts here? Where do you start with this patient? One's brave enough to talk. Okay. So this is a typical patient that I would think about that might present to a primary care office, right? Multiple concerns. I can see that she has obesity. She has probably prediabetes. She has an elevated blood pressure, possibly hypertension. We're seeing some end organ changes with her albuminuria. And then we worry a little bit about her liver too with the ALT elevated. So lots of different things to think about. But starting with, where would you start? And then what referrals would you make? Are we going to send her to endocrinology, to nephrology, to cardiology, maybe to gastroenterology or hepatology to take a look at her liver? So interestingly, there are now a number of cardiometabolic fellowships that are available as well. And I have to laugh because I think when you take this patient as a whole picture, what we're really doing is recreating the primary care physician. And so this is the typical patient that walks into the primary care office. And we, as primary care physicians and clinicians, are more than capable of addressing all of those things. Would we make referrals? Possibly eventually, but I think that getting them started is ideal first. And what I really like about CKM syndrome is that it helps to kind of pull all of these different features together and look at them cohesively rather than saying she has, one, two, three, four different disease states. Really, what we're looking at is that cardiovascular kidney metabolic syndrome. So, to define this, we look at it as a systemic disorder characterized by the pathophysiology interaction among metabolic risk factors, so chronic kidney disease and cardiovascular system. This leads then to multi-organ dysfunction and high rates of adverse cardiovascular outcomes. And this may be a new term for you for CKM syndrome. It was really only coined about 2023. So 3 years ago. But now we are really starting to put some details behind what this looks like and how to treat it and how to treat it appropriately. So it really connects cardiovascular and metabolic as well as kidney. There is some suggestion that we may also want to include MASLD or metabolic dysfunction associated steatotic liver disease, used to be called NAFLD. We want to include that as well. So some people call it CKLM syndrome for cardiovascular kidney liver metabolic syndrome, just because that liver piece is so important. And so the starts of all of this is that it typically originates from an excess of dysfunctional adipose tissue. And this secretes pro-inflammatory or pro-oxidative products that damage arterial, cardiac, and kidney tissues. And it is important when we talk about adipose tissue, not just having excess adipose tissue, but really dysfunctional adipose tissue. So we do see patients who maybe don't have a lot of excess adipose tissue, but their distribution of the tissue is such that it really causes dysfunctional processes and can secrete these pro-inflammatory and pro-oxidative products. So this is what the schematic looks like, and we're going to come back to this, but I just kind of want to give a big overview of what we're thinking of when we talk about CKM. So what I really love about this is that there's different stages, which are great. Everyone loves an algorithm, but it also has stage zero. So stage zero has no risk factors, and that was when we're really starting to talk with our patients about that prevention. Maybe they have family history of this. Maybe they don't. Maybe they just, want to be, as healthy as they can for as long as they can. We're really going to talk about preventing and preserving that cardiovascular health. Stage one, then we see this excess and or dysfunctional adipose tissue. So we start to see the development of overweight and obesity, specifically abdominal obesity, and this in turn changes into impaired glucose tolerance for many. So not everyone, and it depends on what stage, or excuse me, not what stage they're in, but how much adiposity there is as to when that starts to affect them, and that's going to change a little bit for everyone. But in stage one, we really see these risk factors starting to develop. In stage two, there are metabolic risk factors, and now we can see some chronic kidney disease as well as part of that. So this is the time of maybe that patient that we just saw come in our office. So there's hypertension, there might be metabolic syndrome, moderate to high CKD may already be developed, type 2 diabetes, and hypertriglyceridemia. This is only stage two. And so it goes really quickly from stage zero to stage one to stage two, where we start to see this evidence of these metabolic changes that we can then affect. Stage three, then we consider subclinical cardiovascular disease. And so this might be subclinical ASCVD or subclinical heart failure. We also want to think about stage three when there is a risk equivalent. And so this would be a very high CKD in stage four or stage five. Then in stage four is really the clinical cardiovascular disease. So we see congestive heart failure, we see peripheral artery disease, stroke, AFib, and then also chronic heart disease. And so we see lots of different changes along this continuum. What is really good about this schematic, and I like about this, is that we see the arrows going in one direction, but we have to also consider that it can go in reverse as well. And that really is going to be our goal when we start to see these patients. So even though this was a newly coined term in 2023, this is an older disease, right? These are things that have been around for a number of years. And so looking back and trying to put some numbers on these for patients, looking at what the prevalence of this would have been if we would have diagnosed this back in 2000, if this was a term. And so we see that it's been fairly consistent in many of the stages. Stage two along the top has been about equal. Stage four and stage three have been about equal, but we do see a big increase in stage one. And so that is the development of that excess or dysfunctional adiposity. So we have seen that increase overall. And then who doesn't love a good heat map? And so this is looking at the different changes that we see from 2011 to 2023 based on state. And actually, Michigan is not that terrible. We're somewhere down in, towards the bottom, about a third of the way down, as to how much we have seen an increase in the prevalence of these different stages. And these are looking at stages 1 through 4. But what we do see with stages 1 through 4 is a difference in survival. And so that is why it is so important to start to quantify where they're at in these different stages. And so, these colors are a little bit similar, but if you can look at stage 4 is obviously the line that's on the bottom, and looking at that huge drop off in survival probability over a course of years. Stage 0 is at the top and sees the least amount of survival changes, but with stage 4, we do see that drop off. And I mean, that's evidenced by, there is a longer standing disease and there are some things with more consequence. And we do talk about this as cardiovascular disease, and I like kind of always bringing it back to cardiovascular disease, but there's a number of different diseases that contribute to this. So looking at the different CKM stages between 1 and 4, looking at just all-cause mortality, specifically cardiovascular. But then we also see increases in things like cancer mortality, respiratory mortality, digestive mortality, and then other overall. So we see these changes not just in cardiovascular disease, not just in kidney disease, but really across the board of different things that are going to impact a patient's life. So I love this graphic in that it really kind of shows this progressive metabolic dysfunction. And at the top, you see obesity, and you're just like waiting to see all of these dominoes fall, right? But I like that it kind of shows the progression of this. It doesn't just happen like just right off the bat, right? So a person gains weight and it doesn't just happen overnight. We see this kind of buildup that happens. We see this progression that happens. But I also like in thinking that at any point, we can stop this progression. We might not be able to reverse it depending on what the disease process is, but we can at least affect it. And so we can knock those dominoes off the side and not have to see that fall all the way to the bottom. So, in thinking of this concept as a whole, this is really a nice graphic in looking at all of the different things that contribute to each other. And I love that it's a circle because there's not necessarily one thing besides the excess adiposity that's going to start off this whole event. So, we see that excess or dysfunctional adipose tissue at the top. And so then we can see this fat deposited in the liver, and that's where we get things like MASLD. We can see it move into hypertension, dyslipidemia, and metabolic syndrome. And that in turn affects things like inflammation and oxidative stress, insulin resistance, and vascular dysfunction. That in turn then affects both the kidneys and the heart. And we see that reciprocal changes as well. So, all together, we see this as a circle. There's not necessarily just one entry point. We may see it in multiple different ways, but the result is still the same. And the result is still going to be these end organ damages that we talk about with cardiovascular disease or kidney disease. I think one of the really important things to talk about with patients is to start to connect some of these dots and connect some of these arrows. So that patient at the beginning comes in and she says, "Oh man, I've got 5 different diseases." And really, no, no, you have different manifestations of the same disease and the same disease process. And that connection can be really powerful too, in that I'm working on, treating your kidneys because I don't want you to have a heart attack. And that connection is sometimes difficult for patients, but talking about it kind of as a whole and talking about it as CKM syndrome, they start to make those connections a little bit easier. What are we trying to impact? And what kind of long-term things are we worried about? So recently, as recent as June 9th, so just what is it, last week or the week before, I've lost track of the date at this point. So they have had a recent update to CKM, and this now looks at a guideline for prevention, detection, evaluation, and management. And what I loved about this is that it was a joint effort. So we did have the American College of Cardiology, at the American Heart Association. They also included other partners like the ADA, the American Diabetes Association, to start to talk about what does this look like if we take it as a whole and we try to treat it as a whole. Several of those things they pulled out at the beginning as take homes, and there's 10 of them. And I encourage you to go and at least read all of the take homes. I'm going to highlight several of those in the next coming slides, but I don't have time to go through all of them. But it talks a lot about some of the overlapping treatments and the overlapping goals that we have for patients with CKM. So one of the first take homes that they have, and it is the first one at the top, is that CKM staging is recommended for all youth and adults. And so we want to think about those patients who are at risk for this, even if they have no risk factor. So even if they're at stage 0, and many of our patients hopefully will be, but stage 0 still has, things that they can do to prevent any progression to stage 1 or beyond. Stage 1, then, as we talked about, the excess or dysfunctional adiposity. Stage 2, we start to think about the metabolic risk factors, and many of these are disease states in themselves that we're trying to treat. But if we think about this as a whole picture, we're really trying to prevent stages 3 and stages 4. So again, coming back to the schematic, this is a great one to, print out and have in your office. Where are you along this continuum? And it goes really quickly, as I said earlier, from stage 1 into stage 2. And stage 2 seems like, wow, there's a lot going on here already. But that is the key that many, or that's the entry point for many. And we want to start talking about that soon and say, okay, I want to treat you here in stage 2 because I don't want you to get into stage 3 or stage 4. So who should be screened? Who should we put in these different stages? Really, we can talk about this with anyone. And like I said earlier, talking about this with the healthy patients are just as great about talking with those that are already in stage 1 or stage 2. But minimally, we should start talking about this with anyone with obesity, anyone with prediabetes or type 2 diabetes, hypertension, chronic kidney disease, or MASLD. Because often these run in packs. And so we want to think about them together as a whole. And are we screening for all of these things? Are we thinking about all of these things rather than looking at them individually? All right, so I wanted to talk about a patient. So this is David. So David is a 62-year-old man with type 2 diabetes. He's presenting for a 12-year follow-up. Oh, excuse me, he's had diabetes for 12 years and he's presenting for a follow-up. His medical history includes hypertension, dyslipidemia, and obesity. His medications include metformin, basal insulin, atorvastatin, and losartan. He reports mild exertional shortness of breath, but no chest pain. And he's had no prior myocardial infarction or stroke. On his labs, he has a BMI of 32, a blood pressure of 138 over 84, an A1C of 8.1%, an EGFR of 48, UACR is 320, and LDL-C is 78. So, which stage of CKM syndrome best describes this patient using that framework? So, would you say he's in stage 0, stage 1, stage 2, 3, or 4? Does anyone want to volunteer an answer or throw it in chat? 4. So, I have a 4 in the chat. So, stage 4, thinking he has clinical cardiovascular disease. Any other thoughts? 3. Mhm. Yeah, so I think that you could put him probably in stage 3, possibly stage 4, starting to have characteristics of it. Some would think about this in stage 2, but I would say that he probably at this point has some subclinical cardiovascular disease. And we'll talk a little bit more about why and how we're going to stage him for that. So, one of the second take homes from the new guidelines is that we're going to quantify their risk using the prevent equations to look for cardiovascular disease. And we used to use the ASCVD calculators. It is recommended to use the prevent equations. It takes more things into account. These are calculators that are freely available online to use. And it gives us a little bit better idea of where their cardiovascular disease is likely to lead them. So this is their risk score, and that is because of, again, probability of survival, looking at 100% all the way on the left. And as their prevent score increases into that orange range, we do see that level of survival fall off as the years progress. And so we can say with confidence that using the prevent score does help quantify this risk for cardiovascular disease. So other ways of screening are going to be thinking about the other possibilities, other things that contribute to CKM. So we're going to measure things like BMI and waist circumference. So waist circumference is interesting. Hopefully that's something that you are doing in your clinics. If not, it's something that's easy to start. And that's because BMI is great, but it's a population metric. And so it doesn't often give the risk for an individual. And that said, at the lower ends of obesity, so we talk about class 1 through class 3 of obesity, when you get into class 1, those with a higher waist circumference actually have a higher cardiovascular risk. And that's because we see that more of that central adiposity that is more likely to be dysfunctional adiposity. And so utilizing that waist circumference is another way to say, okay, so this is a higher waist circumference that is likely contributing to your metabolic disease. It is also something that is really great in that when we start to see weight loss, it's one of the places we often see it first. And so instead of seeing a lot of changes with BMI, you may first see changes to waist circumference when you're treating overweight or obesity. And that can be a great win for patients as well. So seeing that waist circumference go down. When we think about metabolic screening, again, this is something you're already doing, which is going to be blood glucose and blood pressure. Kidney function, we want to talk about EGFR as well as albuminuria, and we'll talk about that more in just a moment. And then finally, liver disease. So we want to think about screening for liver fibrosis, and we'll talk about exactly how to do that in just a moment as well. If we're doing regular assessment, half of people with obesity but without metabolic risk factors will develop them over the next 6 or 7 years. So this is something that we should be monitoring fairly frequently, especially if they have one that is that is changed, we likely will see the other ones develop shortly after that over the next several years. So it's something that we want to watch a lot closer. But this is one of the ways that we can screen for this and help to stage them into those different stages. One of the other things we want to think about is routinely assessing for CKM risk factors. So, in addition to the ones that we just talked about, other things might be for the metabolic dysfunction associated steatotic liver disease or MASLD, pre heart failure, and then also obstructive sleep apnea. So, those are things that can contribute to risk. So, as promised, screening for MASLD. This paper just came out recently. It was an update to one that was, I think, from 2021. I am one of the authors on these papers, and what it did was look at a clinical pathway for how to screen for MASLD, which used to be called non-alcoholic fatty liver disease or NAFL. And so we want to take those patients that are at risk. We want to do a first non-invasive testing to calculate a FIB4, which is the most accepted. Then, depending on the outcome of that, we would do a second step or a second test, often a liver VCTE or vibration controlled transient elastography. So it takes a look at the stiffness of the liver. And then, depending on that, we put them in the likelihood of having one of four different stages of fibrosis. So the good news about the FIB4 is, again, this is just a calculator and it's calculated from data that you probably already have. So it uses age, it uses ALT, AST, and platelets. And most of us already have that available to us for most patients. So we want to screen them with a FIB4, and that's the initial screening step, and then move on to secondary screening if needed. So, one of the next take homes is to evaluate and address social determinants of health. So, in addition to thinking about their clinical presentation, we have also seen that those with CKM and significant changes or challenges with their social determinants of health have poorer outcomes overall. So we want to think about behaviors, lifestyle. We'll talk about treatment in a minute, but talking about those behaviors to change, but also what are their relationships? What do their communities look like? What are societal factors? What are their health related social needs? What things are they having a challenge with? And as we see more of those go up, we see a higher likelihood of them having mortality. So looking at mortality rates by CKM stage and by social determinants of health burden. So as those go up, so across the board overall, and then one social determinant of health, 2, 3, and 4, we look at the different stages, stage 4 being the red, stage 0 being the green. And as those go up and they have significant social determinants of health challenges, then we see a higher mortality rate. So much so that if you look at the bottom and look at the hazard ratio, the one that's all the way to the left, the CKM and stage 4, has just about as high a mortality hazard as having 4 SDOHs. And so the more the challenges that you have socially, the higher likelihood that you're going to have a higher mortality if you have CKM as well. So in addition to treating medically, which we hope that you do, also thinking about, okay, what are the challenges that this patient is facing to help move from those stages and help move into those, reverse those stages. All right, so now that brings us to a really important question. How do we treat this? If we have put them into our stage and we say, yes, you have these risk factors, you are in stage 2, stage 3 of CKM, how do we approach this and how do we treat this with our patients? The good news of this is it's a lot of the things that you're probably already doing. And in addition, part of the reason to put all these diseases together is that often the treatments are overlapping. And so by offering one or two different options, you're treating one or two or even maybe 3 different diseases. So the first and centrally to everything is going to be lifestyle intervention, or what I like to call behavioral change interventions. Often we're trying to get away a little bit from that term of lifestyle, and that's just because this is a lifestyle, but often it's not necessarily the choices that they are choosing to make or have the ability to change. So what we want to do is to move some of those behaviors into more healthy behaviors and helping them do that. So Overall, looking at things like dietary interventions, increasing physical activity, having options for things like school and education programs, calorie restriction, low fat diets, we can see some of those things that help improve metabolic risk overall. I like to say that the best diet is the one that you're going to stick to. So the evidence-based ones that we see are going to be the Mediterranean diet, DASH diet, low carbohydrate diet, and low calorie diet. And we do see those some good evidence for those. Um, However, again, it's going to be an approach that we need is to talk about this in the patient's realm. And so, with their preferences and their cultural ideals, talking about what changes do they think that they can make. And these may be smaller changes that we move towards and more, taking that time to move more towards that behavioral change. We also want to think about increasing physical activity. So, being realistic about what this looks like, how fast and how much can be attained by the patient. This is going to look a little bit different for everyone. I do like to stress what I expect from those outcomes. And so, often with exercise, we expect to see a lot of weight loss. Exercise is great for cardiovascular health. It's not that great at initiating weight loss, especially if there's no changes in diet or nutrition otherwise. And so kind of putting all of this together is really important, but that's the way that many think that they lose weight is they say, oh, I just started this great new exercise program, but then they get disappointed after 2 months and they don't see any changes on the scale. And that's because they probably are healthier in their cardiovascular health, but not necessarily in their metabolic health. And so we need to see those changes for both sides of the coin. This graphic, and it might be a little bit hard to see, but it does go through kind of what we do at the different stages, although many of the things are overlapping and very similar. So another big take-home message is to assess chronic kidney disease and utilize kidney protective agents. So when we do assess for chronic kidney disease, we want to use both EGFR and UACR to characterize it. And then we want to use both to help guide those kidney protective agents. Hopefully this is very familiar to you, but this is again looking at this heat map of what this chronic kidney disease looks like. So off to the left is the EGFR, and we've used that for a number of years to have these different categories as to what are their quantifying their kidney disease. But then across the top, looking at the albuminuria. And what I do want to highlight is, we can see increased or severely increased albuminuria in that A3 category and still see a normal EGFR. And so it really is important to take both of them into account when we are looking at risk and talking about overall risk of chronic kidney disease. The number underneath is the number of times that we should be seeing the patient and or assessing them, often by labs. And so this is a thing that's often missed. We just say, okay, we're going to check this once a year, and then we're going to treat it, and we're going to check it again in a year. But as we move into these higher red areas, we should be checking a little bit more frequently and reassessing that patient as well. When we get into, this a lot of this and treatment depends on your comfort levels. But once we get into that kind of orange area and certainly into the red, we often refer at that point from primary care to have them under the care of a nephrologist. There are four pillars really of reducing this cardiorenal risk, and this is looking at the treatment. So RAS therapy, SGLT2 inhibitors, MR antagonism, and then GLP-1 receptor agonist. And the cool thing is that really 2 out of these 4 we've had just for the last 10 years. So we are seeing significant changes and significant progression in the ability to treat this cardiorenal risk. So this comes from the KDIGO guidelines looking at treatment for chronic kidney disease. So across the top again, we do have lifestyle or behavioral changes, and then first line drug therapy across the next one. And so SGLT2 inhibitors, they have been great in being able to see changes in that kidney and benefits to the kidney. And again, we've only had these since the early 2000s. And initially they were used in diabetes, but then in the non-inferiority studies, we found that not only were they important in diabetes in decreasing glucose, but they also saw a decrease in cardiovascular disease. That was monumental because up until that point, we could decrease A1C, but we didn't see changes in those macrovascular outcomes. So this was the first class of medications that we saw that in. And then subsequently, we've also seen that in GLP-1 receptor agonists. I also remember the early days of treating with SGLT2s, and it was, okay, what happens if they have kidney disease? Can we still use these? And then thankfully, those studies were also done and shown that, again, not can we use them, but now we can use them and see benefit in chronic kidney disease in diabetes. The other thing that was a big push forward is that now we use these very regularly in those without diabetes. So we use it to affect cardiovascular. We also use it to affect chronic kidney disease. I've heard a nephrologist say these are really kidney drugs with a side effect of glucose lowering. So how this medication started in the diabetes world and then moved into cardiovascular and then moved into kidneys. So this is a cornerstone now of, it's a first line drug therapy for those patients with chronic kidney disease, and we use it and we should use it very soon. The second thing we're going to use is that RAS inhibitor, so the ACE inhibitors and the ARBs, and that still has been a cornerstone for a long time, and we do see significance in that, and do see significance in changes in outcome. And then statin-based therapy, so moderate to high intensity statins. What I really like about this graphic is that all of those are on equal level as first-line drug therapy. So when a patient comes in with chronic kidney disease, we're not just aiming for one target and using one medication. We really should be using all three, and often all three at the same time. Below that, then we have those targeted therapies for any other complications. So we may include a GLP-1 in addition to the SGLT2. We may include a non-steroidal MRA if we need to have that further indication. If we need to have that further blood pressure lowering, we might use a different blood pressure medication. But we have those first line drug therapies and then the sequential ones afterwards. This slide comes from the ADA standards of care. And so this is, again, looking at what we would do with those with diabetes. And so again, lifestyle behavioral change at the top, RAS therapy right away, and then first line drug therapy are going to be those SGLT2 inhibitors and the GLP-1 receptor agonists, as well as including another blood pressure medication if we need, as well as including the moderate to high intensity statin. And off to the left, when it says all individuals, off to the right, all individuals, that includes both those with type 1 and type 2. So we do still see the macrovascular changes in those with type 1, but they start to develop a little bit later. So they often develop after 5 years of having type 1, rather than those with type 2 that we may see those developing at initial diagnosis. And that's because it's been smoldering for a number of years. The one thing to remember about the SGLT2 inhibitors is that we don't have a lot of glucose lowering at the lower EGFRs. And so once they get about to 35 or 25, depending on the agent that you're using, we don't see a lot of decrease in glucose. They are still beneficial and they can still be used and should still be used. But if you need that additional glucose lowering, that would be a time to use a different medication, such as a GLP-1 receptor agonist. And the GLP-1 RAs have been found to be not only safe in chronic kidney disease, but beneficial as well. So we start with SGLT2 inhibitors, but then we can also use the GLP-1s in both those with and without type 2 diabetes. So I love this graphic as well in saying, the different targets that we see within the kidney, what our medications are working on. And you can see that there's GLP-1s and SGLT2 inhibitors. They're working in more than one spot. And that's, again, because the complexity of this with the metabolic changes that we see are not just one thing. It's not just increase in sugar. It's not just a decrease in or an increase in blood pressure. But we have a number of different ways that they're developing dysfunction. But now we have a number of different ways that we can target that with the same medication. So again, using the ACE or the ARB, the GLP-1, the SGLT2, and then the nonsteroidal MRA if we need that as well. And it just kind of shows different areas of that tubule that it affects. On the bottom, it looks at the development, the mechanism development of the albuminuria across CKM. So in different disease states, we're seeing different reasons why that albuminuria can be developing. But then again, we have those different targets that we can hit with our agents that are similar across the board. So these are really the foundational ones that we need to think about when we're thinking about chronic kidney disease, as well as with CKM and all of that overlap, right? Everyone with that CKM, when you get to stage 2 or even stage 3, most should be on a SGLT2 inhibitor, a GLP-1, an ACE, or an ARB, and often a nonsteroidal MRA as well as a statin medication. All right, so I want to pop back to our case of David. So remember that he came in and had a number of things going on. Which medication for him has demonstrated benefit across cardiovascular, kidney, and metabolic outcomes in patients such as him? Would it be A, sulfonylureas, B, TZDs, C, SGLT2 inhibitors, D, DPP4s, or E, insulin? So what are you thinking for him? Yes, absolutely. CCC. So SGLT2 inhibitors. Awesome. That's what we're looking for. And that, again, is that first line therapy that we want to think about for patients with CKM, depending on what their disease state is. And then just a couple open-ended questions to think about. So how does the chronic kidney disease contribute to increased cardiovascular risk in patients with CKM? And then what multidisciplinary or comprehensive management strategies would you implement to reduce this patient's CKM progression and cardiovascular risk? So I don't know if anyone remembers back to the case and wants to comment on either of these, but why do you think that chronic kidney disease, how does it increase risk for that cardiovascular disease? Any thoughts? So remember, we talked about it being almost equivalent to the same. So once we get to stage 3, that subclinical cardiovascular disease, we see it almost the same as when we get to those higher stages of CKD, and that's because we see about the same mortality. And so, looking at the cardiovascular mortality in the top left of this slide, and looking at what the EGFR is doing, we see that as the EGFR decreases, so to the left, we're seeing an increase in cardiovascular mortality. Similarly, on the right, as we see the UACR increase, so more albuminuria, we see that cardiovascular mortality increase as well. And that's because there's often comorbidities along with this. But again, what are the standards of care? So statins, RAS inhibitors, SGLT2 inhibitors, and then often GLP-1. This one happened to be semaglutide in the study that they were looking at. But the GLP-1s, many of them have shown benefit. And so we see improvement with having, often these 4 medications at least that are added to the CKM picture. And then I do want to go back for just a moment and talk about, multidisciplinary or comprehensive management. And you may remember back to the case or not. It was a bit ago, but he was on insulin. His A1C was high. His blood pressure was high. So there's lots of room for improvement, but I would challenge you to say, could we add one medication or 2 medications to help hit multiple targets? So could we add an SGLT2 inhibitor to help decrease his blood pressure, which it would, to help his kidney disease, which he had, and to decrease his A1C? Absolutely, that's considered first-line therapy, right? Could we then add a GLP-1 to help with his weight management and obesity, as well as his A1C, and then as well as his kidney disease? 100%. If we added in one that also has the indication for cardiovascular disease, such as semaglutide, then we're getting that benefit as well. So thinking about these as a whole picture really just makes sense because that's what we're trying to treat. We're trying to treat this whole picture of a patient, and using 1 or 2 agents, at least medically, as well as behavior change, we can hit a number of these different targets. All right, so before we go into conclusions, I do want to highlight a couple things that are available from the National Kidney Foundation of Michigan. So they have a number of different things outreach to both clinicians and providers as well as to patients. And so this is their campaign, Are You the 33%? So 1 in 3 US adults are at risk of kidney disease. And so is that you? And if it is, are you being tested for it? And are you talking about this with your clinician? In Michigan, I wish we were doing a little bit better. So, this is the amount of screening both for Medicaid and Medicare. And we get about 50% that have been screened for chronic kidney disease and diabetes for Medicare, and about 22% for those in Medicaid. So, I encourage you to just add this to your regular labs when you're checking an A1C. Also, check a EGFR and check a urine for UACR. And so we want to do both of those together. And this to me is one of the things that we can affect, and we should be increasing. We should be having just this screening done for chronic kidney disease and diabetes, just as we're doing for A1C. And then patient facing materials. So again, connecting those dots between, why does my kidney matter to my heart? Why does my kidney matter in diabetes? What am I seeing with this? And unfortunately, we more and more people are knowing patients that have been on dialysis. And so I think that that's a really real fear for many as it's becoming a bit more common. So really talking early about what their diabetes looks like, what their kidneys look like, and how we can affect that. So patient facing material, there's lots of different options here. Early testing, early detection, patient education as well, and kind of looking at those numbers. And, again, looking in that, I love it, like the red, yellow, green, just like we saw in that heat map. What is green? What is in the danger zone? And then what is that red that we're trying to steer away from? Patient education then in managing chronic kidney disease. So sometimes things are reversible and sometimes they are not. And managing this in the meantime, once you have developed chronic kidney disease, is important. And talking to our patients about that, we hope that we're catching it early. And a lot of it can be, if not reversible, at least very treatable. But how do we manage this, and how do we manage this day to day? And then some evidence-based programs as well that are available for the patients, and really patients across Michigan. So the diabetes prevention program, I cannot promote this enough. I think one of the biggest benefits that patients find is that they find their peers. And so other people with diabetes that they can talk to, and they often learn from their peers. But there's other evidence-based programs that are available with, often promoting that behavior change. Okay, so finally, I want to talk about kind of putting this all together before I go through some conclusions, and we'll have some time for questions as well. So, really, what CKM tries to do is to pull together the diseases that have a similar etiology. So, the dysfunctional or excess adipose tissue that we see in stage 1 can then promote that metabolic risk and chronic kidney disease, as well as cardiovascular disease in stage 2. What we see then is that progression to subclinical cardiovascular disease in stage 3, and then clinical cardiovascular disease in stage 4. So the key to this, and the key to changing this, is going to be that early identification and early prevention. And again, I really love that we have included a stage 0. And not many staging mnemonics do this. They wait until there is disease that is there before they say that you're in stage 1. But we have a stage 0, and we need to promote that, because if we can change those risk factors and promote healthy activities now, then we can prevent many from moving into stage 1 or the progression through this. Likewise, this is a reversible process. And so we can say, even though we're in stage 1, can we treat it and move back into stage 0? Or likewise, stage 3 to stage 2. It's going to be a longer process, and it's going to take, a lot of different changes, often behavioral changes in addition to treatment. But this is potentially a reversible process. So it's the one thing I would say, if I could change the schematic a little bit, that would make those little arrows go backwards as well as forwards. Think about this as a whole picture. So again, this is what it does: is it connects everything together. I think it connects it very nice for the patients, but it also connects it for the clinicians, and saying, I'm not treating 10 different disease states, I'm really treating one disease that has having 10 different manifestations. Which ones do these patients have, and how can I treat those appropriately? So looking at that holistically and looking at that holistic view for the patient. And so finally, I just want to leave you kind of with a rhetorical question again. What would happen if we treated CKM syndrome at stage 1 rather than waiting to stage 4? And I think that we would see lots of changes overall. I think that we are moving in that direction, especially with medications now that can effectively treat overweight and obesity. They're not right for everyone, but for many, it is really changing outcomes, and it's really changing their progression into these stages and through these stages. So instead of just looking for disease, we're really trying to look for health. It's a very osteopathic principle. And moving back into, can we treat them and identify them and treat them at stage 1 rather than waiting till stage 4? All right. And so finally, my key points from this talk that I hope you walk away from. So CKM syndrome begins years before cardiovascular disease becomes clinically apparent. And that's why, again, we should be treating it in stage 1 rather than waiting till stage 4. Albuminuria and excess adiposity are often the earliest detectable markers of CKM risk. And then things like behavior change, RAS blockade, SGLT2 inhibitors, GLP-1s, and lipid management, so all of those being first line, can simultaneously improve cardiovascular, kidney, and metabolic outcomes. All right, and with that, I think we have a little bit of time for some questions or comments. I would love to hear your thoughts on this. Question. How do we change the culture of medicine that is siloed? For example, the cardiologist won't check a UACR because it's a kidney test. Yeah, that's a really good question. And I don't know that I have the exact answer for that, but I would say that one of the things that I like to work towards is to try to reach their primary care first. And so these, again, are very common things and common tests that we can test for in primary care, and we need to have the ability and the knowledge to do so, as well as the time to look for those things. And then taking those very specialized patients that need that extra help, say in cardiovascular or the nephrologist, and sending them for referrals for that. I would say the other thing is to treat your primary care as the quarterback. And so, knowing the rest of your team is really important. Know your nephrologist, know your cardiologist, so that when you are referring, they may see the cardiologist one time a year. They may not, but if they can give recommendations back to the primary care, that can be done in the meantime, and when they're seeing them every 3 months or so. And so we shouldn't be, unfortunately, we are often siloed, but there are places where we can find that team to effectively treat them. Great question. Another question. So any thoughts about the MRA finerenone? Yeah, so these are the non-steroidal MRA antagonists. And so we can use these and should be using these in those patients that it's indicated for. So those aren't considered our first line, but it definitely is considered that for those patients with chronic kidney disease. So a tool in our toolbox, and again, those 4 pillars of looking at cardiorenal. But that is one of those medications that is newer and not everybody is as familiar with, but that could be a whole kind of presentation in and of itself. And so definitely important and included in those algorithms. If you go back to the KDIGO guidelines, that is included often as a second line, not as an original first line, unless they need, once they need that additional lowering. All right. Well,
Any other questions? Feel free to come off mute and ask if you have any. All right.
All right.
Thank you so much. Elaine has a question.
For those with diabetes, is it appropriate for any of the GLP-1s? So, good question. We do think that it is a class effect of decreasing or showing the benefits in chronic kidney disease. The ones that have been specifically studied have been the semaglutide and the liraglutide. The ones that have not been shown to have an indication quite yet is the combination. So the tirzepatide that has the GLP-1 and the GIP. We think that is mostly due to the GLP-1 side of it, and tirzepatide has a little bit more GIP than it does GLP. So the two that have the cardiovascular indication are going to be liraglutide and dulaglutide and the semaglutide. The ones that are most commonly used and have the kidney indication is going to be the semaglutide and liraglutide. And it really goes between a daily and a weekly, and most people are really using semaglutide for that now because it's a weekly injection. It has the easiest kind of easiest use as well as some of the best indications both for cardiovascular and for kidney. Great question. Okay, well, thank you all very much. I appreciate your time and attention. Hopefully this was helpful, and I'm happy to hear any feedback as well.
Thank you so much, Dr. Pfotenhauer. It was a great presentation. I hope everyone takes away a lot of good information. Once again, thank you for attending. We hope to see you next month at our next Grand Round series. And once again, thank you, Dr. Pfotenhauer, for this wonderful presentation.
Thanks so much.
All right. Well, if there's no other questions, I'll give you a couple minutes back to your day, and I hope that you enjoy the rest of it. Thank you.
Thanks. Bye-bye.
Bye-bye.